Seeing nobody at the microphone here in the room, do we have anything coming in via the web that you want to read? Thank you. So Morgan will be the reader of those email questions.
Okay, our first question comes from Leanne Clitheroe, and the question is this an option for all forms of the disease? If not, then which ones are and why?
So this sounds like a Marnie or Alan question.
Yeah, I'm happy to start. So certainly MRT is available as a potential clinical investigation, not as a therapy in this country, and not even yet as a clinical investigation. But if it were to go down that route, it would be intended to be available to individuals with significant and severe and potentially life-threatening mitochondrial DNA-based diseases. Many mitochondrial diseases are not due to inherited errors in the mitochondrial DNA. They're often due to errors in the nuclear genes. There's hundreds of those, and this would not apply. That would be available to just do general in vitro fertilization with PGD for embryo selection for a nuclear gene disorder. MRT would require an additional manipulation to replace the mtDNA for individuals when that was the source of the problem. And so it would have to be an inherited mitochondrial DNA disease where the mother was known to harbor the mutation and at risk to pass it on through her embryos.
Alan, do you want to opine?
I have nothing to add to that.
Okay.
That's a thorough answer.
Great. So maybe we should go here in the room, and please introduce yourself.
J.D. Hansen from the International Center for Technology Assessment. Appreciated your fourth recommendation that if you're going to do work with female embryos, you needed to have multi-generation animal studies. I would like your ideas on why you wouldn't have multi-generational animal studies for male DNA. I'm not quite convinced that there are no changes with MRT caused in the male embryo that wouldn't be permanent changes. I would point, I started my career working on fisheries biology, but I would point to a 2005 Wuhan hydrobiology study, actually on clones, a little different, but they found that when they put goldfish, put common carp nuclei into goldfish embryos, that they ended up with vertebrae numbers that were those of the common carp, even those of the goldfish, even though the common carp was the appearance of the new clone. So the mitochondrial DNA are controlling the structure of the organism. I would like to know why that isn't the case in, I do understand these aren't clones, they're a little bit like clones, but why aren't there changes passed down to male from the functioning of the mitochondrial DNA that wouldn't need to be monitored in subsequent generations too?
Well, so others can opine, but I think you shouldn't read that recommendation as meaning that there shouldn't be sufficient animal data for initiation of the first human investigations. And so it's really a matter for the FDA to decide when there is sufficient evidence coming from animal preclinical models before initiating that first investigation in males. The three conditions for females we thought were important to articulate. Not to say that the notion of intergenerational effects is not important for first initiation of males as well. And that's a matter for the FDA to address with their expertise. Yeah, sure.
So you bring up a great point about evolution and differences. In fish and in lots of species, mitochondrial DNA can be passed on by either parent, either through the eggs or the sperm. But there's a very heavy pressure for that not to happen in humans and in mammals in general. And so while mtDNA could be passed on through the male in the fish, it's not the appropriate model for these studies because that doesn't happen in mammals. And there is a lot of reasons why if the sperm mitochondrial DNA were to get into the embryo, it's actively destroyed. So while it's very possible that it's possible, it's only been reported in one case report in the history of the literature of human health and disease. And so it's very unlikely that the male mtDNA makes a contribution. And besides that, changes that happen over the lifetime of the individual are typically not passed on, through the germline. And so for those reasons, I don't think that the fish studies necessarily lend, meaningful preclinical data relevant to the human condition.
Yeah, I wasn't talking about the male mitochondrial DNA. I was talking about structural changes, genomic changes triggered by the mitochondrial female DNA in the new organism. So basically that the mitochondrial DNA is actually changing, is interacting with the nuclear DNA in a way that makes a different phenotype.
So I think that, again, I would just reiterate that these sort of highly technical matters were not within the scope of our committee's work, as I think you know. And so we would leave these kinds of questions to the FDA and its advisory committee process to resolve. Anyone else in the room before we go to another web question? Okay, Morgan.
Okay, our next question from Renata Shiska. What factors are taken under consideration while deciding which of the two techniques might be used preferentially, e.g. discarding of the spindle or discarding the zygote?
Alan, that seems like one for you.
Yes, what factors are taken under consideration while deciding which of the two techniques might be used preferentially?
Well, it appears that according to the embryologist that we had give testimony and we spoke to, that the spindle cell mechanism is probably the better. Obviously, you're not making embryos, you're just transferring spindle mechanism, and the phage microscopy allows that to be done accurately. So I think the conclusion was that although wasn't our charge to pick one procedure over the other, it seemed that the spindle cell mechanism transfer seemed to be the preferable course.
And part of, I would think part of what will happen in the coming months and years is that as the techniques are tried in other parts of the world, we'll learn more about the answer to that question.
Sure.
So the UK is likely to move ahead in this area in the coming months.
Okay, moving on. We have a question from Dr. June Ann Gold at Loma Linda University. Do we have any knowledge regarding how many have been done in Europe, and what are the potential side effects?
How many?
I would assume that would mean how many children have been born, or has this technique been tried yet in Europe?
I think we know the answer to that is 0. It's a pretty easy one. So the UK has undertaken a very sophisticated and involved process by which they are moving forward with the regulation of these techniques, but no clinical implementation has happened yet. Yeah.
Okay, the next question from Tian Wang from Fudan University in China. Due to the rarity of mitochondrial diseases, it is difficult to recruit enough patient samples to ensure the validity of the clinical studies. This might take years to generate enough data for clinical translation. Is there a possibility for international cooperation? The study group at Newcastle University in the UK has already started clinical studies in patients, and China also has a large population of mitochondrial disease patients. Would the US authorities use preclinical or clinical data of mitochondrial donation from other countries as a reference on making decisions?
Anna, you want to take that?
Yeah, thanks for the question. So we agree that it's important to take advantage of the expertise and knowledge of that's been developed internationally to ensure that research is conducted in a scientifically valid and ethical way. And so this is actually a great question because it gives us an opportunity to highlight one of the principles that was mentioned in the slides. It's the principle of partnership, so it's a principle for oversight. And in our recommendation, and I have the text of the recommendations here, so I just wanted to read the recommendation if that's okay. And it says the FDA should collaborate with other regulatory authorities within and outside the United States to improve the quality of the data available for the assessment of benefits and risks of MRT. So we really are encouraging partnership among the regulatory authorities to take advantage of the synergies there. And I think that probably Dr. Witten has, from the FDA, might have a comment with respect to this question as well.
Yes, thank you. So I just want to say, in general, we always try to have dialogue with our international colleagues. We have and in this case, we have a confidentiality agreement in place with HFEA, the Human Fertility and Embryology Authority in the UK, which allows us to have discussions with them regarding mitochondrial replacement studies in the UK. So specifically, we could have those discussions. But then more generally, I will say we can accept clinical studies conducted outside the U.S. in support of an IND or an application for marketing. And in 2008, we amended our regulations on acceptance of foreign studies not conducted under an IND to update the standards for acceptance of foreign clinical studies not conducted under an IND, but ensure protection of human subjects and quality and integrity of data from these studies. And there's a final guidance that FDA issued in 2012 called something like Frequently Asked Questions in FDA Acceptance of Foreign Clinical Studies Not Conducted under IND. So we do have the ability to look at clinical data. And then more generally, I think it's always been the case that we would look at other scientific data that people generate, not just clinical data. So if studies are done anywhere across the globe, not just in this setting for this application, but in general, we do look at scientific data from, that's submitted in an application.
Thanks. Anyone else in the room but before we go to another web question? Okay, Morgan.
Okay, our next question is from Sean Murray at the Australian Mitochondrial Disease Foundation. There was mention that any potential future clinical investigation would be limited to someone with severe disease. There was also mention that the patient must be healthy enough to sustain a pregnancy. Is this potentially contradictory? As a specific example, if someone is asymptomatic or oligosymptomatic and carries a known pathogenic mtDNA mutation, for example, M3245A to G, and has a sibling and or other maternally related family member that develops significant disease due to the same mutation, would they be considered an appropriate candidate for using MRT to have a child without the same disease potential?
So I'm going to defer to our clinical colleagues here, so Alan and then maybe Marnie.
So first we address the issue of the health of the mother with mitochondrial disease, and obviously the whole field of perinatal medicine deals with women that have illnesses. Now, if the patient was so disabled that there was the judgment that she couldn't carry a pregnancy, then a gestational carrier is an option for these patients. But most of these patients, the literature is very, very sparse as far as following these patients in pregnancy, but what is in the literature, they seem to do fine.
Yeah. So I think the severity of disease is there to say to acknowledge that there are a lot of variants in the mitochondrial DNA that exist, even at variable heteroplasmic levels, and it's not clear that they would cause disease. So just having a variant is not synonymous with having a disease, and so the indication would mean that it was a known pathogenic mutation that caused disease either in that woman, another sibling in that family, another family member, or just known indisputable pathogenic mutation, not a variant of uncertain significance. I think that was the reason that language was used.
Okay, thank you, Alan and Marnie. Our next question comes from Adam Craig at Drexel University. What research results did the committee study when assessing the possible range and likelihood of unintended health consequences of mitochondrial replacement? How did it choose which prior work to use as the basis for its conclusions? How disparate were the outcomes in these studies? How did the committee arrive at a synthesis on which to base its own assessment of the safety of mitochondrial replacement techniques?
David?
Thank you, Jeff. I should point out that the committee was charged with looking at the ethical, social, and policy considerations of this issue and not directly with safety. Having said that, the committee did review extensively the scientific literature, the 2014 FDA Advisory Committee meeting, and also public comments with an eye at looking at safety concerns. And in the committee report, you can see that the issue of safety and efficacy was a major concern of our committee. In the first recommendation, one of the preconditions to move ahead is for the FDA to assess the safety and efficacy of these procedures. In recommendation 3, one of the guiding principles for the design of clinical trials was to look at safety and efficacy in terms of the offspring. And then finally, the idea of very slowly and deliberately transitioning from male embryos to female embryos is based on a concern about safety. So I think even though we weren't charged with assessing safety, that really was a paramount concern of the committee.
Thank you,
Thanks.
David.
No, go ahead.
Our next question comes from Lori Krieger at the Manoff Group. Given what is known about human evolution at the current time, what broad evolutionary unintended side effects might we encounter through modifying mitochondrial DNA? Do we even understand enough about how mitochondrial DNA works to fully answer that question? And has the perspective of biological anthropologists been solicited?
Well, maybe I'll start and others can chime in. So I want to make sure to be really clear about the description. So MRT does not modify mitochondrial DNA. As we noted, I think, a number of times in the presentation, and we say very clearly in the report, it's a replacement en bloc of existing mitochondrial populations for another. And so it isn't, I think, an issue related to genetic change such that we'd worry about evolutionary effects. That said, there is a tracing of ancestry that comes with the mitochondrial DNA population in an individual. And so we do say something about the effects on ancestry and identity, as you heard from the presentation. However, the numbers of people that it would take to alter evolution in any significant way would have to be much, much larger than anything contemplated in terms of the people who are at risk of passing on mitochondrial DNA disease, as we were discussing. So I think on those two scores, it's not a real concern. Others can add if they would like. Okay.
Okay, our next question comes from Nan Berry, and she asks, with so few individuals who would potentially benefit from this technology, and that is still a big if, why cross that ethical line for so few? Why invest so much money into research if this is only going to be used for so few? Where is the payoff? Proponents deny this is the slippery slope, but how can you defend crossing the line for so few?
Anybody? I've been talking a lot, so I'm looking at my colleagues. Okay, Marnie, please.
I think we're moving into an era of personalized medicine, precision personalized therapies, and this is about getting the right therapy to the right patient or the right preventative approach to the right patient. And so there is, because of the unique nature that we explained of the mitochondrial DNA and the way that it's quarantined inside of the mitochondria, there is the unique ability to remove them. And so it would potentially be the right preventative fit for people with inherited disorders of the mtDNA. So I think the justification comes that it's the precision therapy for that population, which is more than one person, an undefined number of people. And so I think that's where the committee justification was based.
I think it's also worth noting on the question of resource investment that this report does not make any recommendations about how much money should be invested in this particular area of research versus any other, and that as far as the FDA is concerned, they review what is presented to them. They also do not dictate what will be researched or not before it comes to them for review. And indeed, a lot of the work that might need to be done in this field preclinically would likely be ineligible for federal funding due to restrictions on the use of federal funds for research involving human embryos. So to that extent, it would be a series of private choices. So we are not in a zero-sum game where we have a limited public pot of money for which we are deciding how much to spend specifically on this disorder.
Thank you. The next question comes from Panda Kroll at the Ventura County Bar Association. What is the status of the establishment of the House HR Budget Committee's proposed panel of faith-based experts, and how is that proposal not a violation of the Establishment Clause of the U.S. Constitution? Who decides which faiths would be represented in such a panel? As a corollary, would it be fair to exclude a panelist of Buddhist faith?
Dr. Whitten, do you want to speak to that?
All I can say really about the independent panel of experts recommendation is that we're in the process of considering the congressional report, and we can't really comment further at this time.
Okay, thanks. Morgan, anyone else in the room? Okay.
Hi, my name is Michelle Bayevsky, and I'm a pre-doctoral fellow in the NIH Department of Bioethics. So I was wondering how you would define a severe or a serious enough illness that it sort of merits doing mitochondrial replacement therapy.
Yeah, good question. Yeah, please.
So we know more than 400 disease-causing or pathogenic mutations in the mitochondrial DNA. And so there's really a lot of information that are known. Some are very common, like the common MELAS mutation, which accounts for a lot of disease in adults, and others are very uncommon, and some are more or less recently recognized. We know that on average, each person has about 16 different symptoms. And there are many mitochondrial DNA diseases that present and shorten lifespan or result in babies that don't survive infancy, or children that have early demise, or adults. So I think the decision would have to be made on a case-by-case basis, which I believe is also how the UK program is being implemented. But if it's a known variation that is indisputably known to cause disease, there is a lot of information out there to show the severity of disease that results. Often things like strokes in infancy and childhood, severe seizure disorders, cardiac failure, liver failure, renal failure. So these aren't subtle once they hit. And so I think while there's not one variation that you could limit this to, or one sequence change, there's a category of disease that would be different than perhaps just say, a late onset, manageable problem. So I think that's how the decision would have to be made, but again, on a case-by-case basis.
Yeah, I mean, severe and near certain in its inheritance. The other thing to say is that the UK is considering the same question, and so there's going to be a fair amount of learning that happens cross-border on that question for sure. Okay, Morgan.
Okay. Our next question comes from Françoise Baylis at Dalhousie University. Is there published data to support the claim that the desire for genetically related children is widely held?
I don't remember who is. Sorry, was that a Lori question? I don't remember how we knew this one was coming. Was that you or me? I can start and you can think. All right, I'll talk while you think. That's always a good plan for you to get to think while I have to talk. There isn't a huge amount of data about the answer to that question. And we looked very hard for what we could find to help inform our thinking about that question. It's pretty clear that people have opted to take advantage of reproductive technologies in a way that indicates the strong desire on the part of many to have genetically related children. And so we took that very seriously. We heard that from people who came to present at our public workshops. It's pretty clear in the literature, and it's pretty clear just as a matter of practice that is the case. You want to add to that, Lori?
Yeah, I mean, I think we've seen that in terms of the numbers of people who pursue reproductive technologies, and in rare disease communities of people who are pursuing IVF with PGD. And we certainly heard talk of that at some of our open meetings. So that's where I think that judgment comes from, to reiterate some of what Jeff said. And again, I think to reiterate that this is adding an option to families that are interested in having genetically related children.
And then specifically about that belief within the mitochondrial disease community, it was presented to us at one of our public sessions by an expert, and it's now been published in a medical journal. The senior author is Michio Hirano, where a survey was done of patients with mitochondrial DNA disease of reproductive age, and what they did place, their priority on that value, and it was very high. It was on the order of 80 or 90% really value. So I think there is emerging data, but I think it's limited in its scope.
And I think just to reiterate that the language in the report says widely held but not universal value. So I think that's just important to point out that nuance in language.
Thank you. Our next question comes from Marcy Darnofsky at the Center for Genetics and Society. One of the central conclusions of the committee's report is that minimizing the risk of harm to the child born as a result of MRT is the primary value to be considered in assessing the ethics of the balance of benefits and risks. Regarding benefits, the report points to two. One, at a population level, due to the decreased number of children born with mtDNA disease, and the second to parents who desire a genetically related child. Thus, as the report recognizes, children born as a result of the procedure would bear its risks while others would benefit. How does the report reconcile these observations with its conclusion that these germline mitochondrial techniques would be ethically permissible?
Great. So let me start, and then I'm sure others of my colleagues will like to join in. So one, I wanted to be clear that the analysis that led us to conclude that it was ethically permissible to continue with initial clinical investigations in humans of MRT did not rely on that risk-benefit calculation. It was about the ethical issues that were described in the slide deck. However, in order to implement ethically permissible going forward requires a clinical investigation. And so what we said was that clinical investigations needed, if they were to proceed, needed to follow a particular set of principles, including, as you just read out, the centrality of the best interest, minimizing the risk of harm to the potential offspring. And maybe I'll ask Jonathan to say something about that.
Sure. So a couple points. First, there are potentially many interests that are implicated when one pursues MRT. There's the interest of the mother, there's the interest of the child, potentially if it's a gestational carrier, et cetera. So the point about prioritizing the welfare of the child is meant to say that when considering the risks to all these different parties, that the welfare of the child ought to be the fixed point, the anchor point against which one is doing a risk-benefit analysis of the entire protocol. The second point is that to say that the welfare of potential offspring ought to take priority is not the same as saying that there is going to be a zero tolerance for risk to potential offspring. And I should just point out that in any kind of assisted reproduction technology, there are potential risks that are being imposed on potential offspring so that mothers can pursue a reproductive option. One doesn't want to configure research in this realm in a way that is ethically inconsistent with what we view to be acceptable in other realms of reproductive research.
Anyone else want to join in on that? No? Okay.
Okay, and then the final question that we have is also from Marcy Darnofsky. The report states that there are significant and important distinctions between modification of mtDNA to prevent transmission of mtDNA disease through MRT and modification of nuclear DNA. Can the committee respond to comments reported in the media that its conditional approval of mtDNA modification builds the case for approval of germline modification of nuclear DNA?
Let me start on that, and then maybe I'll ask all to join. So we think that there are significant differences and distinctions to be made between mitochondrial DNA, nuclear DNA, and MRT and any kind of genetic modification in the nuclear genome. And we articulated that in the report as well as in the slide presentation. So I don't think that there's reason to say if you allow MRT, then you must allow modification of the nuclear genome. We didn't, I think, believe that. I don't believe that. The analysis, I don't think, supports that. That said, we thought because we articulate MRT as creating heritable genetic change, although it doesn't come from the editing of either mitochondrial or the nuclear genome, that there needed to be, first of all, males only to allow us to better understand the effects intergenerationally, and second, if it's deemed to be safe intergenerationally, to allow the discussion that's ongoing related to the use of human gene editing tools to go forward and reach its conclusion before any consideration of heritable genetic change created through MRT. And to say more about the latter part, I'd love to turn it over to Alta.
Sure. Let me start by reiterating something that Jeff said that I think is very important to understand. This report makes a recommendation to the FDA that if it were to proceed, it begin in a non-heritable form. And that means that the question about heritable changes, which really are the subject of most of the conversation around so-called germline editing, really are not yet implicated by this report. There is an ongoing global discussion about the ethical issues as well as governance questions raised by the use of various kinds of editing technologies, the most recent one being the CRISPR technology. There is a coordinated effort by the Academies of Science and Medicine in China, the UK, and the United States. And here in the United States, our academies have set up a consensus study committee, which will report out by the end of the year, on issues around editing across a variety of application areas that include somatic changes as well as nuclear DNA and, in theory, mitochondrial DNA as well. And there are parallel activities going on in the academies in other countries. The European Federation of Academies of Medicine is having a conversation this summer about those very same things. And so the entire question about heritable changes is one that I think is being discussed in a more integrated and global fashion. And this report focused really primarily on an area that is a narrower range of applications. Last, the debates around human germline editing in its heritable form, because they focus generally on nuclear DNA, were looking at a much wider range of application areas, and also with gene editing, a much greater set of choices in what kind of effect you want to induce with your technology, because this simply replaces wholesale mitochondria from a healthy donor, using the mitochondria from a healthy donor to replace those from a woman whose own mitochondria have mutations. We get very little choice except to substitute one healthier wild type for another. Whereas in editing, the questions are really what kinds of things do you want to edit and in what ways? So the questions are much broader. And this does not necessarily predetermine the outcome of that larger discussion.
And I would just say, Professor Charo also always sounds well-informed, but she's particularly well so in this regard because she's co-chairing the Academy's consensus committee that she mentioned. So I'll shout out for that. All right, any more questions in the room? We're done with the webcast, I guess, because Morgan sat down. Great. I guess with that we can adjourn unless there's other, I'm looking to Ann and others about whether there's anything else for us to do. Dr. Zhao, do you want to, okay. Great. Thank you all for coming. It's been a pleasure, a privilege, an honor, and we will, I guess, be available. We'll stay around for a little bit after we finish. But thank you all, my colleagues, and thank you all for coming.